So what is interpretation? Interpretation is nothing but conversion of radiographical data into useful diagnostic information. So the main objective of today's presentation is to understand how can we systematically scan a radiograph, intraoral radiograph particularly, and to learn the progression of the dental caries into pulp and the periapical region, and interpret these lesions on the radiograph and write a radiographic report. The reading of a radiograph can be described as a systematic scanning and statement of observation. The scanning is started with the first tooth, which is closest to the midline, and then each tooth and its supporting structures are scanned in a predetermined sequence, like the crown, the root, the crown, you have the crown here, the root, the pedial space. You can see the thin radiolucent line is the pedial space. Then the radiopaque line is your lamina dura. What is the periapical alveolar bone? The interdental bone. Okay, what is there present between the two roots? Okay, and the interradicular bone in between the two roots. Okay, and this is between the two teeth. Okay, so you are going to see. Now, what are you going to see in the crown? Okay, in the crown, you are going to see the thickness of the enamel, the dentine, the pulp chamber. Okay, as it is written mentioned here. Then coming to the roots, you'll see the number of roots, a single-rooted or multi-rooted teeth, whether there is any dilaceration, any developmental abnormalities here like dense invaginators, or there is a taurodontism or concrescence, calcification of the root canals. There are so many things you can observe. So you have to see that. Okay. Then we come to the periapical alveolar region. What are you going to see here? You're going to see the trabecular pattern. Okay, so the normal trabecular pattern in the maxilla has got very fine trabeculae, small, numerous marrow spaces. Okay, whereas in the mandible, the marrow spaces are larger and the trabeculae are thicker. Okay, you will see if there is any destruction of the trabecular pattern here. Okay. Then you come to the pedial space. Okay, now what you're going to see, whether the width is uniform, is it widened at the crest, or is it widened at the periapical region? Okay, if there is localized widening in one teeth or there are many teeth generally involved, all this has to be noted. Similarly, you can do with the lamina dura. If you can see the presence, okay, it is continuously present or it is thickened or the discontinuity is there or there is a generalized loss of lamina dura. Okay, all this you have to observe. Then you go to the crest of the alveolar bone. Now this is called the crest. Okay, normally it is around only 1.5 mm from the CG, but now you can see that, this is a well corticated appearance is there. Okay, this is a normal, and here you can appreciate that there is a horizontal loss of it. Okay, so you have to write whether there is a horizontal loss or a vertical difference. Okay. So now coming to the radiograph, now we'll see how dental caries progresses. Okay, into pulpitis. Now this is your tooth. Okay, it's a large carious region. When it is only in the enamel and dentine, you can call it as a reversible or irreversible pulpitis. Okay, and then when it involves the pulp, it will become irreversible, as you can see here. Okay. So now, when this is entirely, the crown portion is involved, then the pulp is involved, this is your necrosis. Now, what is this pink thing you can see is your pedial space. Okay, and all these gray crisscross lines are your trabecular pattern. Okay. Now, after your irreversible pulpitis, when the spontaneous pain is there, and the patient says, I have tenderness and percussion. Okay, then radiographically, what will you observe? Other than the carious lesion, you will see a widening of the pedial space, which is there. Okay, so it is specifically seen in the apex. So this is a widening of the pedial space that is known as apical periodontitis. So this is the radiographic feature of apical periodontitis, where you will see a large carious lesion and widening of the pedial space at the apex. So next, what will we see? Now this is also progressed. Now the lamina dura, which is there surrounding the pedial space, this white line, that is lost here. Okay, and the trabecular pattern, what you can see here, that has become blurred or hazy. So this stage is known as acute periapical abscess, and clinically the patient may have feeling of tenderness of the tooth in the socket, or a small swelling on the gingiva in the vestibule. Okay, so you have the radiographic feature of acute periapical abscess, loss of lamina dura, and haziness of the. Now in chronic periapical abscess, what happens? Okay, as you can see here, the haziness has been, destroyed, and you can see irregular radiolucency in the periapical alveolar. Okay, you can see irregular area of radiolucency in the periapical alveolar bone. So, and this is very ill defined. So, this is known as the periapical abscess. Okay. So, at this stage, and sometimes this may be surrounded by a radiopaque zone around the periphery. So, this is your chronic periapical abscess. So, now we will see them how they look on the radiographs. Okay. So, you can see that. You can see this is first thing you have to identify is this is your intraoral periapical radiograph. Okay, you can see 1, 1, 1, 2, 2, 1, 2, 2 is partially seen. Okay, the crown there is flattening of the cuspal architecture. Come to the root, you can see the roots are appearing calcified. You cannot trace the root canals. Here you can trace. Then there is widening of the PDL space as well as loss of lamina dura here. Okay, so this is nothing but apical periodontitis. Next is your acute periapical abscess. Now, you can see a nice intraoral periapical radiograph showing 4.5, 4.6, 4.7. Identify the normal anatomical landmarks like the canal, the inferior external oblique ridge. Then there is a major proximal radiolucency involving pulp with widening of the PDL space, loss of lamina dura, and there is a haziness. Okay, here you can see the trabecular pattern, large marrow spaces is trabecular, but there is haziness here. So this is nothing but acute apical abscess. Similarly, you can see all these 1, 3, 4, 5, 6, 7. This 1, 6 has a major proximal radiolucency in the crown involving the pulp. You can appreciate 3 roots, major buccal, distal buccal, and the palatal roots, widening, loss of lamina dura, and irregular radiolucency here. Okay, similarly, this is the anterior IOP. Okay, 2, 1, 2, 2. You can see there is a wide pulp chamber. Okay, a very well defined or somewhat irregular radiolucency. Okay, you see the crest. There is so much of horizontal bone loss till the middle third of the roots. Okay, this also has to be identified. Now you will see other things. This is the lower anterior IOP. 1, 2, 1, 2, 3, 1, 3, 2, 4, 1, 4, 2. Flattening of cuspal architecture significant of at region, and there is a ill-defined radiolucency. Okay, and you can see there is a zone of radio opacity here around the periphery. Similarly, here with this 4, 6, okay, there is a irregular radiolucency as well as sclerosis around the bone. Okay. Similarly, in this tooth also, these are root stumps. Loss of structure is seen in the crown, and radiolucency surrounded by a radiopaque zone. So this is nothing. All these dotted structures are sclerosis of the periapical. Now we saw pulp necrosis, apical periodontitis. Next is it can either go into abscess or into granule. Okay, so you have a very well-defined periapical radiolucency, which is less than 1 centimeter. Okay, but there is no hyperastotic border. That time we'll call it as a granule. Now, if this radiolucency is well-defined, more than 1 to 1.5 with a wide border, then it becomes a radicular or periapical cyst. Now we'll see some cases. Okay, when it is more than that, 1.5 with a hyperastotic. Now these are, IOP radiographs, variously involved in the pulp and a well-defined apical radiolucency. In this, in the mesial root, you can see in this premolar with the secondary caries, in the anterior teeth, which is endodontical treatment is going on. Similarly here, so all these are well defined and they are less than 1 or 1.5, then you call it as the periapical granule. Now see this IOPA, foreshortened, this is a fault here, always identify the fault. It's very important you recognize the errors in the radio. This is shortening is there, you have given a very high vertical angle. Okay. So this is 2, 1, 1, 1, 1, 2, 1, 3. This is a well-defined round or oval radiolucency involving 1, 1, 1, 2, sometimes 1, 3 with a hyperestotic radiopaque verticated border. So this is very more than 1.5, then it is a radicular cyst. This is how you identify a cyst. And if this border is not continuous, it's absent, then it becomes infected cyst. So partial loss is indicative of secondary infection. It is an infected body. So now we saw abscess, we saw granuloma, we saw cyst. So sometimes when the virulence of the microorganism is low and the deposition of bone is there around it, then it is known as a combination of rarefying as well as condensing. And when there is only deposition of bone, then it is a condensing osteitis. Occurs when there is virulence low and our immunity is good. Ill-defined irregular radiopacity in the periapical alveolar bone. So you can see this cariously involved tooth. You can see diffuse sclerosis. Okay, both the teeth. This is the premolar. In the crown, pulpal involvement, root single-rooted widening, loss of lamina dura, and irregular radiopathy. In the dental alveolar crest, you can see there is a horizontal bone loss around 5 to 6 mm below the CEJ. So this is a moderate periodontitis also. Now we will see how to write a report. Okay, now you see. First see what type of radiograph, IOPA, bite ring, occlusal, panoramic. Okay, then identify the normal landmarks. Okay, I can see a suture. This is a septum. This is a soft tissue outline of the nose. Okay, anterior nasal spine. Then identify the teeth. 1, 1, 1, 2, 2, 1, 2, 2. An error is this is a cone cut here. This looks like taken with the help of RVG. So there's a cone cut. And then I'll tell this is a radiograph showing all these things. 1, 1 appears normal. The crown and the root are intact. Then 1, 2, same thing. Then in 2, 1, what I can see in the crown, it's little cut here, but I can see there is a wide pulp chamber and the root canal. And the apex is not formed completely. Okay, maybe there was early trauma. And then I can see a large, well-refined radiolucency extending into the 2, 2. Okay, this is the 2, 2, but the hyperestotic border is absent. Similarly, loss of lamina dura at the apex. So it's an infected periapical cyst involving T1 and 2, 2. You can see all these landmarks. And the errors are the partial image as I told you. So it's very important. First, you should know what are the different sequelae, how they look on the radiograph. Then you can systematically scan it. Don't just come to the conclusion that, okay, this is caries, this is abscess. But systematically do it in an order.